This here is a study looking at the risk of getting severe COVID-19 when the situation that you have been contaminated. So it has been made. Let me see if I can change. Yes, it's made with a whole bunch of collaborators from Rigshospitalet, Bispebjerg Hospital, from DIKU and from other departments, from Danish Medicine Agency, etc., to try to do this. When you see the result we are presenting, it doesn't really merit to being like 40 people on the team, but the idea was we wanted to do this fast, and I'm going to show you the timeline a little later. And we were all in a situation that we were at home. So we have more time to research those. So we're looking at Denmark. We're looking at the eastern part of Denmark, Region Hovedstaden and Region Zealand, the whole population here. And then we are looking at the patient data we can get from the Sundheds platform, the Common Epic platform, and from the national registers for these patients. So this is the population we're looking at. So you can see we started out looking at, so this was in mid-April. We had 2,900 subjects that had been contaminated, and then they have different trajectories. Luckily, 1,700 of them, the next stage they had was without contamination. They were then healthy, but some of them went to hospital. Some of them went directly into intensive care units. Some went first to the hospital, then into intensive care unit, and unfortunately, some of them, 238 in total out of this population, died in the end. So what we are looking at are these stages. So this is a subset of the trajectories. We are looking at how do we get to the various levels. So these transitions, if you are contaminated, what is the risk that you go to the next level, etc. So the inclusion criteria is this: that you're living in these regions, that you by April 28 had a positive, that you have a COVID-19 test, and also that you have been in contact with secondary health care. So that is those that we are looking at going into hospital. And among those, you now know that we have 2,886 patients that were actually positive. Then the way we were looking at it was that we did a random selection of testing versus training to see what can we learn from, what is the risk to go from one level to the next. And then we are looking at if you're in hospital, what is your risk of dying? What is your risk of admission to the intensive care unit? And what is the risk that you would need ventilator treatment? We trained this just looking at the patient history. So that's what in the electronic health record until you had the test. Then we could also augment that with all the lab tests that were made during your time in hospital. We could augment it with a chest x-ray taken in the hospital. And then we could take the two, or look just at the chest x-ray and augment the two first models with a chest x-ray. So these are different models with varying amount of information we trained. So here you see the timeline, and here I come back to the why did we need to be 40 people doing this? basically a week after Mette Frederiksen made the close down of society, we had the first draft of the idea. Everything was running very fast. So 6 days later, we actually had sent a funding application to the Novo Nordisk Foundation, and the day after that one was granted. So I wish research funding was always this fast. Normally we have to wait 6 or 8 months from sending in an application to getting a negative answer. So on April 9, we got the legal approval from Styrelsen for Patientsikkerhed to access all the data. And on April 10, we got the approval from the board of directors of the region. They actually did this on Skærtorsdag. They assembled to give this approval because there was an urgency in these matters. And 4 days later, we had the first data in our secure cloud called Computer Roam. And further 14 days later, we had the first models. They have been later consolidated and slightly improved and so on. But I'm going to present you the results of what we did during this 1 month of work during the spring. Things have not changed dramatically since then. The results, they are not published yet, but they are in final. It takes time, just like you know with the Mads study and so on. You try to publish somewhere, it's rejected, and then you go to another journal. It takes time, but it has now been accepted, but not published yet. So let's look at the first results. So the model we are looking at, that is, if you have a positive test, will you go to hospital or will you not go to hospital? And if you go to hospital, will you go to the ICU or not the ICU? And then a separate model looking at, if you are positive, will you survive or die? We could not make that as a natural step after the ICU because actually quite some patients do not go to the ICU before they die. I'll come back to that a little later. So this is a very, a very busy table here, but you should notice a couple of things. Basically, those that attracted the disease in the first wave were quite old, 53 years old on average. Those that are not going to hospital, they are younger. Those that are going to hospital, they are older. If you are first in the hospital, there's no difference in age whether you go to ICU or not, but there's a very big difference in age, those that survive the disease and those that are actually dying. So those that died in this first wave in the capital and Zealand region of the disease were on average 80 years old. So another thing to look at, similar story here for the BMI, the difference is not that big, but actually it's very significant that those that go to the intensive care unit are those with a high BMI. And if we look at gender, we can also see that the males attracted the disease less than, so men more than women, but men were more often dying from the disease in the first wave. And likewise, diabetes is an important condition to have when you are judging the risk of people. So, and one last point is whether you're suffering from hypertension or not is also a very important risk factor we can see by just looking at the statistics. Here you can see the admission per age. Those that are admitted to hospital, we have some that are actually quite some that are below 10, and then we see an increase in frequency by age. When you look at going to the intensive care unit, we have a drop that the very old patients are not going to intensive care unit, and that is normally because they are judged not fit for ventilator. They are simply not strong enough to be able to receive ventilator treatment, and then there's no reason to go to the ICU. So that's also why we see that even though a lot of them are dying, they're not going to the intensive care unit before that, because they can simply not have the ventilator treatment. That's too dangerous for them alone. So let's look further about the risk of going these steps. We have trained a random forest algorithm, because we have tried other models later on also, but the results I'm going to give you here now is for the random forest, and that is because it's a very stable machine learning algorithm. We're looking at this so-called area under the curve. What you should know is that if it's 1, we are perfect in separating out those that are going to die or not die, and if it's a half, then it's random. And you can see here the first results, that we, for each stage progress, we are at an AUC about a little less than 0.8. So we are quite good, but far from perfect in predicting who is going to the next stage. If we are looking just among those that are contaminated, it gets easier and easier and easier to predict the more severe stage we are going to, because basically they're standing out as a subpopulation that has severe conditions. So it's easier to predict whether you are dying from the disease than to predict whether you will be allowed to the hospital during the disease trajectory. And finally, if you're in the hospital, it's a little more difficult to predict whether you're going to die or not, because we have taken all the healthy patients, those that will definitely not die out of it. I have many more results I could present here, a lot about which are the most important features and so on. There's not time for doing that now. I also have a lot of results on using the deep learning on the X-rays, as I said in the beginning. I don't have time to present these, but what I can say is that the X-rays are extremely important for when people are admitted to hospital. The first X-ray they have to say whether they would need ventilator or not, and that makes a lot of logic, that it's actually the condition of the lungs that are predicting whether you later on in your disease trajectory will need the ventilator treatment or not. So I think with that, I'm going to stop here for the sake of time, because I'm over time, also because I had problems getting into the Zoom in the beginning. But thank you for your attention for this.
There's a question from Fritz to your presentation, Mads. Maybe you could answer that in the chat.
Yeah, so could you read it loud, because when I'm sharing, I have a hard time seeing.
Yes. Fritz says, is COVID-19 only those tested to have COVID-19, or extrapolated those that actually had COVID-19?
So these are those that were tested. So our inclusion for being in this study was that you had a COVID-19 test. So these were those that we were allowed to look at from Styrelsen for Patientsikkerhed.
So if there's 36% men amongst them, this might be consistent with 50% of the population being male and female, right? Because, you know, it could be that men just are twice as likely to not want to be tested.
Yes.
Okay.
So
thanks.
It's something we have seen internationally. Also this, that men test less, but have more severe disease trajectories. So that's a general trend, and not just in Denmark.